Hello everyone in CardioMinds channel and welcome to part 2 of the topic of primary electrical diseases. In part 1 we discussed long QT syndrome, short QT syndrome and catecholaminergic polymorphic VT. In this video we are going to discuss Brugada syndrome, early reporization syndrome and idiopathic ventricular fibrillation. And again I dedicate also part 2 to my mentor and professor, Dr. Osama Diab, who passed away in 2018, by whom I get many of the knowledge I present to you today, and if it wasn't for him, this lecture would not come to you in this form, and also the animation and Photoshop in this video are his own design. Let's start with Brugada syndrome. One of the most famous information about Brugada syndrome is that its incidence is high in Southeast Asia, where it had been described as sudden unexplained nocturnal death syndrome due to the high incidence of sudden cardiac death during sleep, previously known in the Philippines as to rise and moan in sleep, in Japan sudden and unexpectedly ceased phenomena, and in Thailand death during sleep. We remember this diagram for the action potential in the sodium-dependent cells, which are the atrial and ventricular muscle fibers. So what's happened in Brugada syndrome? There is inactivating mutation in the sodium channel, resulting in premature sodium channel closure that affects mainly the epicardium due to a pathogenic genetic variant in the sodium channels. This results in a voltage gradient between the epicardium and endocardium during the plateau phase, generating an electrical current directed towards the epicardium, reflected as a positive deflection in the precordial ECG electrodes shown as ST elevation. So as we see in this animation, normally the sodium channel is open to generate vaporization and then close, but in Brugada syndrome they prematurely close, resulting in voltage gradient between epicardium and endocardium. An additional mechanism that there is delayed activation of the long-lasting calcium channels in the plateau phase, resulting in prominent action potential dome in certain areas, while other areas don't have this dome due to failed activation of these calcium channels or increased I2 current of phase 1 of the reporization. This results in heterogeneous loss of action potential dome, resulting in phase 2 reentrant circuits due to voltage gradient between certain areas. So as we see in this diagram that there is a prominent voltage gradient between certain sites in the heart. As we can see here, the epicardium is the main area to be affected due to failed activation of sodium channels, and other areas may have action potential dome as we can see here. This results in voltage gradient and phase 2 reentrant circuits that can result in VT or even BF and sudden cardiac death. There is a controversy regarding Brugada syndrome, as the early description of RV structural abnormalities and RVUT conduction delay in those patients sets the stage for the current controversy over its pathophysiology, whether it is just a channelopathy or it is a cardiomyopathy due to detection of abnormal fibrosis in the epicardial RVUT. So it is not just like long QT syndrome or CPVT that is structured in normal heart. By MRI or biopsy, we can find abnormality in the structure of the heart, reporization or depolarization abnormality, genetic basis or non-genetic, and so it is proposed that the final common pathway for Brugada syndrome could be viewed as a disease of reduced RVUT conduction reserve. That's why we are going to find a certain difference in the management of Brugada syndrome from the other types of channelopathy like long QT or CPVT. The main age of incidence for Brugada syndrome is in the 3rd and 4th decade of life and resulting in polymorphic VT rather than monomorphic. So there is a late age of onset than CPVT and long QT syndrome. In type 1 Brugada syndrome, which is the most famous type of Brugada, there is J point elevation more than 2 mV with cove-shaped ST elevation and T-wave inversion in at least one right precordial lead, either V1 or V2 or both of them, when they are positioned in the 2nd, 3rd or 4th intercostal spaces, as we are going to speak about elevating the right precordial lead position to the 2nd spaces. Either it is spontaneous or induced by administration of sodium channel blocking medication in patients suspected to have concealed Brugada syndrome or type 2 or type 3 without a spontaneous type 1, which we call provocative test using adrenaline or flecainide. So the frank ECG features of type 1 is a curved ST elevation more than or equal 2 mm together with negative T waves in the right precordial leads, and the terminal portion of the ST segment is gradually descending. While in type 2 and type 3, the ST elevation here is different as it is saddleback ST elevation, which is less peculiar than the pathognomonic curved ST elevation in type 1, positive or biphasic T waves rather than being negative, and the terminal portion of the ST segment is elevated more than or equal 1 mm in type 2 and less than 1 mm in type 3. That's why type 1 is a spot diagnosis that is very easy to be diagnosed, while type 2 and type 3 may need a challenge test to confirm the diagnosis. We have a different protocol to put the ECG precordial leads if you are in doubt of your diagnosis. We can put V1 and V2 in the second intercostal space rather than the fourth, as by this way they are directly opposing to the RVUT, which is the main site of affection, and we can put the 6 precordial leads close to the parasternal line rather than spreading them till the mid-axillary line. By this way, we are more clearly seeing the features of the Brugada syndrome, and the distinguishing ECG features are more clearly visible. We have two types of a challenge or provocative test for Brugada syndrome, which are the adrenaline and the flecainide test, and we have explained them in detail in the video of workup of ventricular arrhythmias. We can use them when we are suspecting Brugada syndrome as in patient with family history of Brugada or sudden arrhythmic death syndrome or resuscitated cardiac arrest without evidence of structural heart disease, and we have explained these two tests in detail in the video of the workup of ventricular arrhythmias. But the problem that the provocation with drug or fever is less specific for Brugada syndrome, as it has 2 to 4% prevalence in healthy subjects to have a positive test and higher prevalence in patients with AVNRT or even an accessory pathway, showing the features of type 1 Brugada syndrome, and the patient doesn't have actually Brugada. And so, to diagnose an induced type 1 ECG pattern with a challenge test, it is required to have other clinical features like documented polymorphic VT or VF, arrhythmic syncope, or agonal breathing during sleep, because sometimes the patient may develop the ventricular arrhythmia during sleep. So if there is a family member, he can notice that the patient has some agony like gasping during sleep, suspecting that this patient developed life-threatening ventricular arrhythmias during sleep, or relevant family history of already diagnosed Brugada or of sudden arrhythmic death syndrome. So Brugada syndrome is diagnosed in a patient with no other heart disease and spontaneous type 1 Brugada ECG pattern, or in patient with no other heart disease but they survived the cardiac arrest due to VF or polymorphic VT and showing type 1 ECG features induced by sodium channel blocker challenge or during fever. And if you diagnose Brugada syndrome, the genetic testing for the SCN5A gene responsible for the sodium channel is recommended also for the probands with Brugada syndrome. And we can also diagnose Brugada if a patient have induced type 1 Brugada features if they are having at least one of the following. They have arrhythmic syncope or nocturnal agonal breathing, family history of Brugada syndrome, or family history of sudden death at age less than 45 years with a negative autopsy and circumstances suspicious for Brugada. Also, it may be considered in patients with no other heart disease who have induced type 1 Brugada ECG without other clinical features. There are certain high-risk criteria in a patient with Brugada syndrome putting him at a higher risk for sudden cardiac death. In the ECG, extra precordial ST elevation involving the limb leads, short-coupled PVC in the ECG or the ambulatory ECG recording, fragmented ST segment or QRS fragmentation suggesting structural abnormality. In the EP study, short effective refractory period of the ventricle less than 200 milliseconds during an EP study, or inducible VT. So how would we treat this patient? We should tell him to avoid certain medications that may induce ST elevation in the right precordial leads like sodium channel blockers, calcium channel and beta blockers, which are contraindicated in Brugada syndrome, nitrates, and cholinomimetic. And there is a link in the description below the video mentioning the medications that are contraindicated in Brugada syndrome. The patient should also avoid cocaine, cannabis, and excessive alcohol intake, and treat fever with antipyretic medications because, as we know, that fever is a precipitating factor for ventricular arrhythmias in Brugada syndrome. There is an important concept to put in our minds that the risk of arrhythmic events in Brugada syndrome patients with unexplained syncope is 4 times higher than the risk in asymptomatic patients. That's why ICD is the first line of treatment to be recommended in those survivors of cardiac arrest or having documented spontaneous sustained VT, and also it should be considered in patients with type 1 and arrhythmic syncope. Otherwise, go for loop recorder to diagnose any ventricular arrhythmia in patients with unexplained syncope. Then it comes the role of antiarrhythmics as a second line after ICD. Quinidine is the most famous to be used to be considered in patients with Brugada syndrome who qualify for ICD but having contraindication, refusing ICD, or having recurrent ICD shocks. Quinidine would reduce the recurrence of ventricular arrhythmias. Cilostazol, which is a phosphodiesterase inhibitor, can be an alternative in some situations to quinidine, and isoprenaline infusion should be considered in patients with Brugada suffering from electrical storm. Isoprenaline is the first line here. A question that usually comes to my mind, and I think that it comes to your minds as well: how is quinidine effective in Brugada syndrome despite being a sodium channel blocking medication? Here it inhibits the potassium channel of the I2 current in phase 1 of the reporization, and so it decreases the I2 current and lessens the attacks because it reduces the voltage gradient between the different cardiac sites, because as we know that the increased activation of the I2 current may result in difference between certain areas due to generation of action potential dome in certain sites and failure to generate it in other sites, resulting in phase 2 reentry. So quinidine reduces the incidence of reentry and ventricular arrhythmias. Although we refused EP study and catheter ablation for long or short QT syndrome or CPVT, it has an important role in Brugada syndrome. Catheter ablation of the triggering PVCs and or the RVOT epicardial substrate is a class 2A in Brugada syndrome patient with recurrent appropriate ICD shocks refractory to medication. So it comes after ICD and using medical treatment. Ablation here of the fibrotic substrate in the RVOT can suppress recurrent VF and normalize the ECG in more than 75% of patients, and in those with recurrent episodes of VF triggered by a similar PVC morphology not responding to medical treatment, catheter ablation may target this PVC that commonly originates from the RVOT or the Purkinje system. What about asymptomatic Brugada syndrome patients? They represent about 2/3 of the total patient. A patient with a spontaneous type 1, but he doesn't have any clinical features and no significant family history. Here there is a role for programmed electrical stimulation during an EP study to look for inducible VT, and ICD may be considered in selected asymptomatic patients with inducible VF during an EP study using up to 2 extra stimuli. But we don't put ICD or start medical treatment spontaneously without an EP study. And the big no, that sodium channel blocker test is not recommended in patients with prior type 1 Brugada syndrome because it is a spot diagnosis. I don't need to have a provocative test. And catheter ablation in asymptomatic patient is not recommended. We only use it after putting an ICD, starting medical treatment if the patient is still symptomatic. After this, it comes role of catheter ablation. This diagram explains how to manage a patient with suspected Brugada syndrome. First of all, we deal with a patient who has no documented ventricular arrhythmia. If he is having spontaneous type 1 Brugada syndrome, exclude alternative diagnoses that may be consistent with the ECG, for example, ischemia that may result in ST elevation and may be confusing with Brugada syndrome. Follow the general recommendation and advise the patient to avoid specific trigger, and sodium channel blocker test has no role here. If the patient is not having any syncopal episodes, so just follow up. But if the patient is complaining of syncope and is suggesting of arrhythmic syncope, so go for ICD still recurrent symptomatic ventricular arrhythmia, start quinidine. Still recurrent, go for catheter ablation. If no feature suggesting of arrhythmic syncope and is considered to be unexplained, go for implantable loop recorder. If the patient has no spontaneous type 1, so there is a suspicion, we should exclude also the alternative diagnosis and then ask if the patient having arrhythmic syncope or nocturnal agonal breathing. If no features like this, check the family history. If it is normal, so discharge the patient. If the patient is having significant family history of Brugada Syndrome or sudden arrhythmic death, go for sodium channel blocker test. And then the results, if they are negative, discharge the patient. If they are positive, so follow the general recommendations and follow up the patients. If the patient is already having arrhythmic syncope or nocturnal agonal breathing, so also there is a role to perform sodium channel blocker test to confirm the diagnosis. If the results are negative, so further evaluation is needed according to the guidelines of the ESC of syncope in 2018. If the challenge test is positive, so go for ICD implantation. Still recurrent, start quinidine. Still recurrent, go for catheter ablation. What about if the patient is having sustained VT or aborted cardiac arrest? In this case, we should also exclude alternative diagnosis consistent with the ACG and then check whether the patient is having spontaneous type 1 or not. If he is having spontaneous type 1, follow the general recommendation, go for ICD directly, and there is no role here for sodium channel blocker test. Still recurrent symptomatic ventricular arrhythmia, start quinidine, or still go for catheter ablation. If the patient is not having spontaneous type 1, so go for sodium channel blocker test to confirm the diagnosis. If it is negative, so further evaluation for alternative causes is needed. If it is positive, so follow the general recommendations and go for ICD. Still recurrent, go for quinidine. Still recurrent, go for catheter ablation. Now let's move to the second type of channelopathies today, which is the early reporization syndrome. Let's first differentiate between the early reporization pattern, which is J point elevation more than or equal 1 mm in two or more adjacent inferior and or lateral ECG leads, as we can see here in this example, while early reporization syndrome is the ACG feature, but the patient here is resuscitated from polymorphic VT or VF without any evidence of heart disease and having the early reporization pattern in ECG. So the first one is just a benign finding reported in about 5.8% of adults and more common in young males and athletes. And there are certain high-risk features that increase the likelihood that this patient may have also early reporization syndrome, not just a pattern, like prominent G wave elevated more than or equal 2 mm, dynamic changes in the J point, horizontal or descending ST segment, and diffuse early reporization pattern in ECG leads. So we diagnose early reporization pattern if the patient is having just J point elevation more than or equal 1 mm in at least two adjacent inferior and or lateral ECG leads. Here we call this patient having just a pattern, but he is considered to be early reporization syndrome if he is resuscitated from unexplained VF or polymorphic VT in the presence of the pattern. So every patient with early reporization syndrome is also having the pattern, but not every patient with early reporization pattern is considered to be having early reporization syndrome. We consider the diagnosis of early reporization syndrome in a sudden cardiac death victim with negative autopsy, negative medical chart review, and his or her ante-mortem ECG showed evidence of early reporization pattern, so this dissident should have early reporization syndrome. And don't forget that the first degree relatives of early reporization syndrome patients should be considered for the clinical evaluation to check early reporization pattern in their ECG with the additional high-risk features that we mentioned before, and genetic testing in those patients may be considered as class 2B due to the low diagnostic yield and the low utility of genetic testing compared with the other channelopathies like Progada, long QT, or CPVT. So how would we treat those patients? ICD is the first line of treatment in patients with early reporization syndrome who survived a cardiac arrest Otherwise, loop recorder should be considered in patient with early reporization pattern and at least one risk feature like family history of unexplained sudden death or family history of early reporization syndrome or having arrhythmic syncope. The role of antiarrhythmics here is for quinidine, the same as in Progada, as we consider both as subtypes of J-wave syndromes. So quinidine should be added to ICD for recurrent VF or VT in early reporization syndrome patients. So it is a second-line treatment after ICD because it blocks the transient outward I2 currents of potassium channels as we mentioned in Brugada Syndrome. Isoprenaline also should be considered in those with electrical storm, the same as in Progada, and remember that cilostazol and milrinone, which are phosphodiesterase type 3 inhibitors, reduce the recurrence of VF. Sometimes we are confused which one to choose in certain patients. We can choose one of them in individuals with early reporization pattern and they are having arrhythmic syncope and additional risk features. They are not strictly indicated for ICD immediately. You can choose from both of them, like patients having family history of unexplained sudden death or family history of early reporization syndrome. And also you can choose one of them in asymptomatic patients who have high risk early reporization pattern in the presence of family history of unexplained sudden death at young age, like prominent J-wave more than or equal 2 mm. It is a high risk feature here because the cutoff point is just 1 mm and dynamic change in J point elevation of more than or equal 0.1 millivolts. Catheter ablation has a role here to ablate the PVC in patients with early reporization syndrome and recurrent VF episode triggered by a similar PVC morphology, non-responsive to medical treatment, usually originating from the Purkinje system with a success rate of 87 to 100%. So also catheter ablation has a significant role in patients with early reporization as in Brugada syndrome. And the big no for this syndrome that clinical evaluation is not recommended routinely in asymptomatic subject with early reporization pattern. So please don't terrorize your patient if he is having just the pattern without having any clinical symptoms or any significant family history. And the ICD implantation is not recommended, of course, in asymptomatic patient with isolated early reporization pattern. This diagram summarizes how to manage early reporization pattern. Ask yourself if the patient had aborted cardiac arrest or not. If he had, so go directly for ICD implantation. Still recurrent ICD shocks, start quinidine. The patient is having electrical storm, start isoprenaline and also quinidine. Still recurrent, go for catheter ablation of the PVC triggers. If the patient didn't have aborted cardiac arrest, check whether he is having arrhythmic syncope or not. If the answer is yes and the patient is having other high-risk features like high-risk ECG features or family history of juvenile unexplained sudden death or early reporization syndrome, so go for loop recorder, then ICD or quinidine as class 2B. If there are no high-risk features, just loop recorder is indicated. If the patient didn't have any arrhythmic syncope and he is having high-risk features, so go for loop recorder, then ICD or quinidine as class 2B. If there are no high-risk features, just loop recorder. If there are no symptoms and no high-risk features, just no further investigation needed. Then the last electrical disease to be discussed today is idiopathic BF. As we can see in this ECG, this patient may have short-coupled PVC, which induce something called R-on-T phenomena that comes in the vulnerable periods that may induce polymorphic VT up to ventricular fibrillation, resulting in sudden cardiac death. From its name, it is called idiopathic. So we diagnose idiopathic VF in a survivor of sudden cardiac arrest with documentation of VF, but after we exclude underlying structural disease, channelopathy, metabolic, or toxicological etiology. So it is diagnosed by exclusion. It's class 2B to perform clinical testing for the first degree family members of those with idiopathic VF due to the low diagnostic yield, like history taking, ECG, and hypercordial leads, exercise test, and echo. But of course, we are going to look for them because sometimes we may detect other features in the family members that may raise a suspicion of a specific disease, and the significance here for detected early reporization pattern in asymptomatic relatives is uncertain, and in idiopathic BF patient, genetic testing of genes related to channelopathy or cardiomyopathy may be considered, but with a low genetic yield of a genetic mutation. How would we treat idiopathic BF survivors? Of course, from its name, I would go directly for ICD and the antiarrhythmic drugs like isoprenaline, verapamil, or quinidine for the acute treatment of an electrical storm or recurrent ICD therapies in patients with idiopathic VF, but the ICD, of course, is the first line. And quinidine, the same as in J-wave syndromes, should be considered for the chronic treatment to suppress an electrical storm or patient with recurrent ICD therapies. We can note here that quinidine is a common treatment in the 3 channelopathies described today, but usually after ICD. Catheter ablation may also have a role here, but by experienced electrophysiologists, because it would be difficult in patients with recurrent episodes of VF triggered by a similar PVC morphology not responsive to medical treatment, usually originating from Purkinje system, and also with an acute success rate of 87 to 100%, the same as in early reporization syndrome. So the summary of the management of idiopathic BF, that ICD implantation is important and genetic counseling and testing may be needed. Patients still having recurrent ICD shocks, you can start acute treatment like isoprenaline, verapamil, or quinidine, and chronic treatment here is quinidine, of course. Still recurrence, go for catheter ablation of the PVC triggers. So we have reached the end of part 2 of the primary electrical diseases. And as we have a summary for the most important one today, which is Brugada Syndrome, the first line treatment, of course, is ICD. Once the patient is symptomatic, he has a very high risk for sudden cardiac death, followed by starting medical treatment like quinidine if the patient is still having recurrent ICD shocks or refusing or contraindicated to put an ICD, or isoprenaline in case of electrical storm. We can think of EP study and catheter ablation in case of electrical storm or repeated ICD shocks to ablate the PVC triggers. And don't forget to advise your patient to avoid hot weather or bath, alcohol, heavy meals, and also avoid specific medications mentioned before. The early reporization, which is also a J-wave syndrome, have nearly the same management, but put in your mind to differentiate between early reporization syndrome and pattern, and the idiopathic VF, we go directly for ICD and also starting the medication in case of recurrent ICD shocks, and to think of catheter ablation if the patient is still having repeated ICD shocks after medical treatment. Thank you very much for watching this video of part 2 of the primary electrical diseases, and we are going to move to another specific disease resulting in ventricular arrhythmias next week.